The next speaker for today's session is Dr. Lanjewar sir. Sir is a retired professor of pathology from Grant Medical College, Sir J.J. Hospital and Gujarat Adani Institute of Medical Sciences. He has served as the director of AIDS Research and Control Center in Mumbai and is an administrator for the Maharashtra Medical Council and the Maharashtra Nursing Council. He played leadership roles in professional organizations, being the president and secretary of IAPM and dean of Indian College of Pathology. Sir has international research experience, being a guest researcher at institutes in Netherlands and USA.
Good morning, everyone. I'm Dr. Sridevi Murpuri, Department of Pathology, D.Y.Patil, Nehru, Navi Mumbai. So I'll be discussing the autopsy case. So this is the case history provided by Dr. Lanjewar sir. So a 55-year-old female was admitted for altered sensorium, high-grade fever and distension of abdomen for 3 months duration. She is a known case of diabetes mellitus, hypertension and hypothyroid. There was no spontaneous breathing. Heart sounds were not heard. 6 gram per dl, which is decreased. There is protein which shows decreased total protein, and of admission she came with the 3 complaints, which is the altered sense, which was 7.6 gram per dl and MCV encephalopathy with hepatorenal.
Which disease you suspect in liver?
So because she's having metabolic syndrome like diabetes mellitus and hypertension, I could think of non-alcoholic steatohepatitis, which is common, and she's a female and no alcoholic history is given. So I can think of that.
Any other comment? Comments from the house?
Considering hypothyroidism, can we attribute the middle edema to
Yes, sir.
hypothyroidism?
Yes, sir. We can.
How did we consider, what did we take into consideration to rule that out? Why was it not part of the differential?
So for the pedal edema. So because ascites also present, sir. So she's having since long. Maybe it can be called, like it can be there. Hypothyroidism.
Would hypothyroidism also cause altered sensorium?
Yes. Treatment, yeah. And there was nothing was provided regarding that. So
But the entire liver is replaced by metastasis. It will not cause incapacity.
We also got diabetic ketoacidosis.
yes.
Diabetic ketoacidosis.
Because she was
Good suggestion. Very good suggestion. So, any other comment or should I?
Any MRI brain was done for this patient?
So history was not provided.
So unconscious sudden sensorium change and all, we do MRI brain.
Not
Because
yet.
we-
Sonography has been done. Sonography and CT scan.
Ma'am,
Anything
that
So you have a case. Okay, and this must be happening in your hospital. 3 days, some investigations are done, some are not done. Okay? Should I go there?
We were hoping for ultrasound, CT.
Yeah, possible.
Abdomen.
Yeah, we are now in a modern era. All sophisticated investigations are available with us. Most of us think that these investigations are sufficient to make a diagnosis in a patient. Today I am taking you to a golden era of pathology. From which we learn the real pathology. And this golden era of pathology is now vanishing. It is disappearing from major institutes, and it is not available in all private institutes. And Therefore, just to inform you, the significance of clinical autopsy, I am presenting this case. And these are the findings of external examination. She was moderately built and nourished. Rigor mortis was present. Pallor was present. She was more pallor. Edema over feet was present. Abdomen was distended. In situ examination, the findings were serosal surface of the stomach was congested and it was distended. Stomach was very much distended. Heart showed some cardiomegaly. Lungs were normal and kidneys were enlarged. These are the photographs of the heart. We are looking at the pericardial surface anteriorly. Showed heart was enlarged. No pericarditis. The left ventricle is opened up. We are looking at this left ventricular wall. They are slightly thickened. It measures 1.4 centimeter. I wish to focus your attention to this root of the aorta. Look at this coronary ostia. They are never visible. They are highly placed coronaries. That can reduce the blood supply to the heart. But in addition to that, around the ostia, there are atheromatosplia. So, highly placed coronaries and atherosclerosis of coronary ostia. Number 2, look at this thoracic aorta. Small raised yellowish plaques are seen everywhere. So in this particular photograph, the diagnosis is cardiomegaly due to left ventricular hypertrophy and atherosclerosis of aorta. Both lungs are focused over here, right lung and left lung. Both were of normal size, pleura was normal. There was no pneumonia. Bronchial tree was normal. So, in total, the lungs were perfectly normal. The examination of a brain, slice of the cerebrum and cut section of the cerebellum and the vessels at the circle of Willis are presented. The cut section of cerebrum is perfectly normal, no hemorrhages, no masses. Cerebellum also shows same feature, and circle of Willis do not show any aneurysm. This is what it is. Now you are looking at enlarged kidney. This is the right kidney, left kidney. Both kidneys were enlarged. They were cystic. The cyst contained hemorrhagic and clear fluid. This is a cut section of this. You cannot identify any cortex and medulla. So, the multiple cysts not communicating with each other, they go in a favor of polycystic kidney. The additional thing was there. Beneath the left kidney, in a retroperitoneum, this isolated mass was visible. We did not know at that time, but I will show you. This is that mass. It was quite big, 5 centimeter by 3 centimeter by 2 centimeter, and this is the cut section of that. Can any resident have an opinion on this? Which organ it could be? It is showing lobulation. Only two organs in the body show lobulation. One is your parotid gland, and second is your pancreas. This is ectopic pancreas. It is retroperitoneal ectopic pancreas. Now, ectopic pancreas, it is not a common site. Very unusual site for ectopic pancreas. Next, the liver. The capsular surface of liver showed these raised cystic lesions. And you can see these cystic lesions. No cirrhosis, no metastasis. Except for this, liver was perfectly normal. And this is the duodenum, C of the duodenum. This is where pancreas is attached. You are seeing mucosa. And in the mucosa, you can see this small hemorrhagic area. I will call it as ulcer, hemorrhagic ulcer. Same thing is shown in higher magnification. It was there. So there was small ulcer which was present in the second part of the duodenum. And then the second part of duodenum was open like this. You can see this. This is the pancreas which are attached to the C. There are the common bile ducts. It was penetrating into the pancreas. So ulcer of the duodenum, which was hemorrhagic, was penetrating into the pancreas. And this is the stomach. So looking at the stomach, see this congested appearance. Whenever any hollow organ shows hemorrhage on external surface, you will always notice congested appearance. This is what it is. The entire stomach, it was full with a blood clot. And blood clots, they are also present in a duodenum as well as in the pancreas. The spleen is there, it was congested. And this still has, you can see this, the shape of the stomach. The complete blood clot has acquired the shape of the stomach.
It's chronic hemorrhage.
Clot, immediately, it is immediate event. Summary of pathologic findings: cardiomegaly due to left ventricular hypertrophy, with high pressure coronary ostia, hypertrophy of ostia and aorta, bilateral enlarged polycystic kidneys, retroperitoneal ectopic pancreas, polycystic liver, duodenal ulcer perforating into head of pancreas, massive blood clot in the stomach, blood clot in duodenum and tissue. These were the findings on cross-examination. Let us see what has happened in microscopy. This is the histology of the kidney. Very few normal glomerulars were visible. This is a large cyst. From outside you can see it is lined by cuboidal epithelium. Rest of the glomeruli, the hyaline line, it is the interstitial fibrosis. So we have labeled it as autosomal dominant polycystic kidney disease, which occurs 1 in 400 to 1 in 1,005. 5 to 10% of these end in the end stage in the disease. And it is caused by mutation in genes polycyclin 1 and 2. Now these are differential diagnosis of polycystic kidney. That is for you. You will. The next slide is the liver. You can look at hepatocytes over here. And these are the cysts. And these are also cysts and extensive fibrosis. Dilated solitary cysts lined by cuboidal cells and fibrous in liver. Now, it is one entity what is called as autosomal recessive polycystic kidney disease. It presents with congenital hepatic fibrosis. And it starts in early age. Our case is not congenital, it is just a fibrosis which is there. But there is no cirrhosis. Okay? Next. Now this is a histology from the duodenal ulcer. We are looking at this ulcerative part, and this is the inflammatory cells, acute inflammatory cells, and the wall of the duodenum, and this is a higher magnification. If you can identify, you can see some filamentous structures. If you cannot identify, these filamentous structures can be seen over there. Small filaments entangled over there, which were AS positive. And you can see acute angle branching. All these acute angle branching indicates that it is aspergillosis. Now remember one thing. This is a morphological diagnosis of aspergillosis. No fungal infection can be confirmatively said unless cultural studies are carried out. Okay, so this is my morphological diagnosis. And this is the pancreas, normal pancreas. And you can see there is more fibrosis, some inflammatory cell, some features were like of chronic pancreatitis. And this is the pancreas, which is ectopic pancreas. Now you can see this acina, this duct, endocrine structure. So ectopic pancreas are also divided. This ectopic pancreas type 1, it is seen in 0.25% in general population and 14% in autopsy material. It means that it will show all 4 components of the pancreas. And the ectopic pancreas in addition showed this fat necrosis. So this fat necrosis was there. I have no answer why it appeared there, but it was there. So type of pancreatic heterotopia, type 1 typical pancreatic tissue with acina and ducts are there, and islets are there. This is similar to normal pancreas. This was present in our case. The other 2 shows only ducts. Type 3 shows only acini tissue. Type 4 shows only islet cells. Now conclusion after histopathology. Bilateral polycystic kidney disease, autosomal dominant, polycystic liver, retroperitoneal ectopic pancreas, duodenal aspergillosis, massive blood clot in the stomach and small intestine. And this is the immediate cause of death. Hypovolemic shock due to massive bleeding in stomach and small intestine, secondary to aspergillosis of duodenum. This is the diagnosis. Do you think we have learned something from this case? Yes or no?
Yes, of course.
We have learned. We will learn
Yes,
some
of
more
course.
things.
But
So what did we learn? Yes, madam? Or sir?
Yes, sir. I want to know that the bleeding was there. Was there the pseudoaneurysm of the gastroduodenal artery? Was it seen there? That kind. Such a massive bleed in the stomach. So there should be a pseudoaneurysm of the gastroduodenal artery.
No, there was no aneurysm. So the ulcer was there. Ulcer was there.
It was the ulcer bleeding.
Ulcer can bleed. So clinically unsuspected disease was identified at postmortem. And this disease was polycystic kidney disease, ectopic retroperitoneal pancreas, aspergillosis of duodenum, and massive GI bleeding due to duodenal aspergillosis. Now let us go what we have learned. Primary duodenal aspergillosis is immunocompromised. Very rare phenomenon. Very rare, only one report is there. That too, this patient was also of diabetes mellitus. Our patient was also of diabetes mellitus. And rarely, duodenal candidiasis can also be seen in patients with diabetes mellitus, and they also can produce ulcer. And this is because they have oral candidiasis. It can be swallowed, it can go to stomach. Most of the time, the gastric juice does not permit this fungi to grow. But if there is ulcer, they can grow and can cause a serious disease. Second point, our patient was of renal failure. all parameters were of renal failure. Creatinine was increased. Arterial nitrogen was increased. Renal failure itself can cause bleeding. If there is no ulcer, still I have this. So I think this has added more and it has given rise to extensive bleeding. Ectopic pancreas is a condition where pancreatic tissue is located outside the pancreas. This tissue can be found in various locations in body, including stomach, duodenum and small intestine. Rarely pancreatic heterotopic tissue may be found in colon, spleen, liver, mediastinum, lung. Ectopic pancreas can be asymptomatic or may present with symptoms such as abdominal pain, GI bleeding or obstruction. Only one report of ectopic retroperitoneal pancreas is documented in literature. That too, it was documented by radiologists. There is no association of ectopic pancreas in autosomal dominant polycystic kidney disease. Now, let us look beyond. Why our case had a diabetes? There is association, diabetes mellitus and autosomal dominant polycystic kidney. Some literature says there is no association of diabetes. Recent reports suggest that association between autosomal dominant polycystic kidney disease and metabolic derangement and particularly impaired glucose metabolism. And autosomal dominant polycystic kidney disease is a risk factor for diabetes mellitus following renal transplantation. So subject is not yet fully studied, and there is a possibility that there is association. Hypertension, we all know that any kidney disease will give rise to hypertension, and there is a problem with renal angiotensin aldosterone which causes hypertension. Hypothyroidism is patients with autosomal dominant polycystic kidney disease show higher incidence of clinical and subclinical hypothyroidism. Therefore, our patient has this. All these are associated. Changes in TH level have been detected in approximately 80% of patients with chronic renal syndrome. Both things are there. So renal failure is also there, and autosomal dominant polycystic kidney is also there. So clinico-pathological correlation. Patient had anemia. This anemia may be because of kidney problems, because there is a decrease in erythropoietin production. Disorientation is because of raised ammonia level in blood. Renal failure, abdominal distension, bilaterally enlarged kidney, and ascites, edema with renal failure, sudden collapse because of massive GI failure. This case is from Grand Medical College, Mumbai. I was working there for 25 years, and our pathology was learned in a postmortem. And because of that, we were able to produce books for our students which tells the value of clinical postmortem in medical institutes. With this, I conclude my presentation. Thank you very much. Did you learn something new?
Yes.
Yeah, I also learned new. because I have to read for everything explanation.
One thing is there that we take diabetes and hypertension as just lifestyle diseases and don't investigate further. I think if we had looked at this patient who came, known case of diabetes, known case of hypertension, a simple sonography would have found this polycystic kidney disease quite early. And I think as clinicians, we just take, umar ho gayi hai, diabetes hai, so you just start treatment. So I think that's probably a big take-home lesson, that we need to investigate every case of hypertension or diabetes to know its primary cause before saying it's just because of age or lifestyle.
Hypertension after 4th decade, we must investigate for polycystic kidney. They present at that time.
But Lanjewar, in this case, only cysts were there in the liver.
Liver and kidney.
Liver and kidney. Because the cysts are known to occur in other organs also.
Yeah, they were
Like
not there.
spleen,
They were not
breast,
there.
even in brain.
Yeah.
Most of the organs
The
they
brain
show
shows
such
the
a case.
aneurysm. Peri-annuity.
No, I'm talking about the cysts that were shown in liver.
Yeah.
They can occur in other organs in such a
Yes, sure.
added polycystic disease.
Yes.
That's very important. We have to look for that. Thank you.
Thank you, Lanjewar sir, for outstanding discussion. We are very grateful for the knowledge that you
I
shared.
wanted to ask, what was the clinical diagnosis before the death? There was no provisional diagnosis.
Before postmortem, I asked. They will say renal failure, diabetes, hypertension, they are all of them.
Sir, has questions.
Not a question. There was a term used NASH, isn't it? So what is that?
Non-alcoholic steatosis.
And any new terminology is emerging? Now it is emerging that it should be called as metabolic dysfunction associated SH.
I thought you were asking me question.
Comment भी नहीं कर सकता.
I was shattered.
Comment भी नहीं कर सकता.
I request the HOD, Dr. Sudhamani ma'am, to present Dr. Lanjewar sir with a memento.
तीसरे अंदर ऐसे फेलिसिटेशन में तुला बोलली तू भी आयचं